Live. Good morning or good afternoon or good evening, according to the time zone where you guys are at. We are here for a new appointment of a live talk for Journal of Cardiac Surgery. This monthly appointment organized by the Journal of Cardiac Surgery, where we discuss one of the paper of the journal and the current issue. This month, the paper selected was aortic valve replacement in patients over 60, real-world surgical outcomes. Paper written by the most senior author is Naren Moorjani from Royal Papworth Hospital, United Kingdom, that is here with us and will be part of the conversation. Together today, we will have Jessica Forcillo from the Centre Hospitalier de l'Université de Montréal in Canada, where that wrote an excellent discussion on the paper that you will find on Journal of Cardiac Surgery in the current issue. Again, soon after, we will discuss the paper with Francesco Maisano, international and well-known cardiothoracic surgeon from the Ospedale San Raffaele in Milano. And together with us, we have Thomas Salerno, Editor-in-Chief of Journal of Cardiac Surgery from University of Miami, Dr. Mario Gaudino, Deputy Editor of Journal of Cardiac Surgery from Cornell University, New York, and Hirbaz Ahmed from Yale University in I6, and editor with me of the social media component of Journal of Cardiac Surgery. For everybody who is watching us through the social media, I remind you that you can ask us questions, and all of these questions will pop up in my private chat, and I will be able to moderate them and re-forward to the audience. I wanted to give the floor to Dr. Moorjani from Royal Papworth Hospital, who was the most senior author of the paper, and he will introduce the paper for us, and he will discuss a little bit the findings of this paper. Thank you, Dr. Moorjani.
Gianluca, first, just to thank you and the team for giving us the opportunity to present some of the work we've done, but also the concept that what you've put together here about live debates, discussing topical issues in cardiac surgery, I think is so important in modern day medicine, and it's important we have the opportunity to discuss and debate these different topics. This topic that we wrote the article on is obviously very interesting and controversial. Actually, at the moment, there have been a lot of trials recently that have been moving the bar about which patients should undergo intervention for aortic valve disease through surgery or transcatheter techniques. And as the indications seem to be changing, both from the clinical trials and also the international guidelines, we felt it was important actually to put some real world data out there about what happens to patients who undergo surgical aortic valve replacement. So as I'm sure will come out in the discussion later, a lot of the trials focus on highly selected patients. These are industry-funded studies with very strict patient selection criteria. And so we just wanted to say we're with the biggest center in the United Kingdom. We do a lot of cardiac surgery. We do a lot of aortic valve replacements. We just wanted to put out some numbers about the outcomes for the patients that we operate on. So we took 4 years of patients. That's over 1,000 patients under aortic valve surgery, and we wanted to just give you some contemporary outcomes of what we achieved. So of the 1,000 patients, about 85% were low risk, defined by Euroscore 2 of less than 4, and about 15% greater than Euroscore 4. And these gradings are what we looked at some of the outcomes later in the presentation. So we had about 26% of our patients were of the age group 60 to 70. The majority were between 70 and 80, so 45% of patients, and about 30% of patients were above 80. So the full spectrum of cardiac surgical patients. This manuscript was obviously concentrating on patients over 60. And later on in the study, some of the different outcomes we looked at between the low risk and high risk, as well as the different age groups, to give us an idea of which patients we should be looking at. and especially related to what the current guidelines are, the recently published AHA and American guidelines. Just as a general overview of the patients, the median Euroscore 2 was 1.6, median age was 75. About 20% of the patients were urgent, emergency, or salvage. And again, this is important to remember in a lot of the studies that were done, a lot of the prospective randomized studies with their selection criteria. This is all patients, urgent, elective, emergency, including endocarditis patients. And again, we didn't have any inclusion-exclusion criteria with our patients, just anyone who had isolated AVR during that period. Of note, the majority of our patients in our hospital were done through median stenotomy. We've got a small percentage of patients that are done through less invasive techniques, and the majority in this patient cohort had bioprosthesis. Some of the outcome measures, which we'll talk about later, how they relate to some of the big prospective randomized studies, showed that the stroke outcome was 1.2% in our cohort of patients, and the pacemaker rate was 3.6%. And this is really pertinent when we compare it to the surgical arms of the intermediate risk studies, Partner 2, the Partner 3, and the Evolute and Notion studies with the low risk patients. The outcomes of our patients, stroke 1.2%, pacemaker 3.6%. Similarly, mortality, in-hospital mortality was just 0.9%. This is in all patients, emergency, elective, urgent patients. And similarly, our 30-day outcomes mortality was just 1.7%. And in our elective cohort, which is when you look at some of the other studies, the low-risk patients and the intermediate-risk patients, our elective study across the board was 1.1% mortality. Similarly, the outcomes after surgery in terms of complications, return to theatre rate was about 3.7%, consistent with our national average. Acute kidney injury of about 20%, AF about a third or just under 40%. Our hospital stay was 8 days, and our intensive care unit stay and ventilator was 24 hours, so just around 1 day. To try and put these results also in context, we looked at 1 and 2 year survival, and they were 94% and 92% in our cohort overall. And then again, when comparing with some of the low risk studies that we'll talk about later, it was 96% and 94% survival for 1 and 2 years. As part of some of the other studies we've done at our own center, which is one of the discussions that will come up later when we're trying to discuss surgical AVR with transcatheter techniques, we looked at our freedom from structural valve deterioration. There's lots of published data out there, 6% at 10 years, 9% at 15 years, and our own data for where we predominantly use the Carpentier-Edwards manganese bioprosthesis, we had no structural valve deterioration at 5-year median survival. So that is the outcomes that are out there for TAVI, and that is the benchmark, the gold standard that we need to compare to. So in summary, I'd just like to present our data that shows in a high volume UK center, we have excellent outcomes, and this is what we need to base our discussions on when we talk about some of the prospective randomized studies. And of note, these are superior to the outcomes that are often discussed in the surgical arms of those studies, which I'm sure will be part of the debate that we talk about. So thank you for that opportunity. And as part of this debate, I'll value the opportunity to answer some questions related to our study.
Thank you so much, Dr. Morgiani. And this is in name of all of the people involved here today. I want to thank you for the paper, for submitting to Journal of Cardiac Surgery. It's a phenomenal and very well-written paper, and we all enjoyed to read it. And Jessica, you were asked to write an editorial. It was an excellent editorial on the paper. You are a successful surgeon involved in transcatheter, and in fact, like the paper of Dr. Morgiani start from a feeling that most of the cardiac surgeons around the world have felt, that is the fact that we feel a little bit frustrated by the representation that the low-risk TAVR versus SAVR trial have given of the surgical arm. What was your thinking when you read? What was your editorial? What are your taking home message from this paper?
Yeah, thank you, Gianluca, and thank you for the invitation. I think this conversation is really pertinent. So, Dr. Morjani, I would like to congratulate you again for this great paper. And this serves as a concrete proof that SAVR remains an excellent option with favorable outcomes in the treatment of aortic stenosis. And what this paper did, to me, it was a wake-up call to the to the entire surgical community to push forward to ameliorate to improve outcomes and reduce complication through innovation and experience. And I think that the previous randomized trial taught us a great lesson, because as you can see, and we're going to discuss about that, the surgical community changed a little bit their practice. So as you can see in Dr. Morjani paper, the majority of the valve implant was 21, 23, 25. In the Partner 3 trial, it was not what is seen in the actual STS registry, where 60% of the valve implant were less than 23 or less. Majority of the surgeons were now implanting 23 and 25. And I think that there is a wake-up call, like we said, and it's important that we continue to improve our results. And another paper that showed that was the Commence trial, when Dr. Bavaria at the STS this year presented the 5-year results. Contemporary data on surgical AVR are actually excellent, and bigger valve implanted. So we are changing our practice. We published also a paper from our group in Journal of Cardiac Surgery about the trend of change over time, TAVR and SAVR. And we see that the results are actually excellent in the contemporary era, as TAVR outcomes are increasing, but also surgical outcomes are increasing. And this is also based on patient selection. And I think we're going to discuss about that.
Fantastic. Thank you so much, Jessica. Thank you for your points that are well taken. Francesco, so if it is true that surgeons feel frustrated for the results or the way in which surgery has been depicted, has been described by this randomized trial industry sponsor that changed the guidelines. On the other side, surgeons are also responsible for the last 30 years for not innovating aortic valve surgery, or for not trying to embrace transcatheter, rather trying to be hostile against this technology. What are your thoughts? What you're thinking? What do you think about this new the position of TAVR and SAVR in the current era?
Okay, so first of all, we talk a lot about low-risk trials, and we should really inform our colleagues that low-risk trials were conducted in very selected patients. And I think instead of talking about low-risk trials, we should start talking about young patients and old patients. To be very honest, in an older patient, even if a patient is low risk, I have a huge doubt, that in an old patient, SAVR remains an option. I think I agree with the current guidelines. I mean, to expand TAVR in older patients with ideal anatomy. I mean, we need to change the paradigm. Rather than being stubborn and say we can do great surgery even if the patient is 85, no comorbidities. I don't agree with that. And I tell you why. And I tell you from my perspective, which is a perspective of a surgeon who has no bias since probably more than 15 years. I mean, in TAVI and SAVR at the same time. The problem is that besides outcomes can be excellent also with surgery. I don't disagree with that. Still, TAVR is a much easier operation for an older patient. And we know that we don't have to talk only about mortality and PV leak. I mean, this for sure, these are indicators, but think about quality of life. To regain quality of life after surgery in an 80 and older years old patient, it takes months, 3 to 6 months, which represent 5 to 20% of their overall life expectancy. So if I'm older, I don't want to go through a long time for recovery. So in the older population, we should really understand that this is a great solution. As we go younger, then we need to be more strict. And the only way to really foster an appropriate approach to TAVR, the only way is to be part of it, is to be able to offer this solution to our patients. Is the way. I mean, as a I don't want to be called hybrid because I hate it. I'm not a hybrid surgeon. I am an unbiased surgeon because I have all the spectrum. In my practice, very often I convince my patients that surgery is much better than TAVR, but just because I have no bias and I am very convincing because of that. So in general, I think I like the point that basically the results are getting better also in surgery. And I think the low-risk trials, the Part 2, Part 3, have been very important to raise awareness in the surgical community that we need to implant better valves, larger valves. We need to be as much as possible less invasive. We need to be perfect. But still, that doesn't mean that TAVR doesn't play a big role and will play more and more in the future in the elderly population. As you go lower with the age, well, I have a lot of doubts.
I totally agree with that. For the patient that are 75 and over, I think that TAVR should be the way to go if there is no other contraindication. The challenge will be for the ART team, and that's where the implication of cardiac surgeons are really important and relevant, is to know which patient would benefit more for the TAVR and which one will be more for a TAVR.
Excellent point, Francesco. I think age is becoming an element that has to be discussed, and I totally agree with you that, like, when you see a patient in soon after a TAVR, the day after, and is ready to go home, or it's tough to say that in an older or fragile patients, it's not what you want. It is what you want. And maybe if we have solid data to prove that the long-term data are the same and we can overcome the perivalvular leak or the stroke or the pacemaker and make them to a very, very low rate, we can even extend the indication. On the other side, American College of Cardiologists, in the current guidelines that were just released a couple of months ago, have put a very interesting age as class 1 indication for TAVR. And I don't want to say, because I mean I'm a biased surgeon. So for how much you are unbiased, I'm a biased surgeon. But I was very surprised by reading those guidelines and see that there was a class 1 indication for TAVR in patients 65 or older. What is your personal take? Like a patient walk in your clinic, Francesco and Jessica, reply, both of you. A patient walk on your clinic is 65 years old. Where do you drive the conversation? Is low risk? Is still working? Is a professional CEO of a company? Is very busy. Wants to go back home as soon as possible and working as soon as possible. Where do you drive the conversation with him? And what do you try to not convince, because you are not trying to convince, but where do you think will be the best choice for these patients?
Jessica first.
Please, Jessica.
Okay. So like we all said, I'm a biased surgeon. And I think that's really great that I'm involved in both of the procedure. 50% of my practice is TAVR, 50% is surgery. So I think I'm in a good position to advise my patient in the proper way. So basically, what is a low-risk patient? A true low-risk patient is a patient with a low STS or low Euro score. It's a patient that has no indices of frailty. It's a patient that lacks any major organ system compromise and has no procedural impediments. If I have doubt, I do not hesitate to ask for a TAVI angioscan prior, even if the patient is a little bit younger. So this patient needs to fit in this category of low risk, really a low risk patient. A lot of patients now are coming to the clinic and they know about TAVI. They read it on the site on the internet. So that's another thing as well. So they can arrive in your clinic with a preference. But at sometimes, but patient preference is supposed to be important. It's important, and I think that we should consider it according to the lifestyle of the patient. And some of the patient also, you need to discuss about them because they are ready to take a low risk option in favor or in exchange of less favorable outcomes. So I saw that as well. But you need to discuss with the patient and influence them in some way about the things that are still unknown for a low risk patient, especially 65 years old. And you need also to think ahead of what will be the second procedure, because probably those patients, if you are to opt for a biological option, you need to think ahead what will be the second procedure. And we can also discuss about that. Mechanical valve is still a valuable option, even if the guideline decrease at 50, but I think you should be honest and present that option as well. Basically in your head, knowing what's happening with TAVI and what can happen with PPM, PVL, durability, subclinical thrombosis. I think you don't have to expose everything to the patient because I think it's more technical and it's a bit more our stuff, but usually 65 low risk patient I will advise for a surgical AVR, but we'll truly discuss with the patient about his preference as well, what he knows, what he think, and what he foresee for the future.
So first of all, we need to I want to tell you one thing. The youngest TAVR I did has been 38 years old. And this was in the year 2007. So as much as you can imagine, I'm a crazy guy. But this was a young guy who had a degenerated tissue valve. At that time, there was not much experience in valve-in-valve, and it was a good idea. I mean, that just to say that you don't have a recipe that works for everybody. You need to be very flexible. And there are two things I would like to share with you. Number one, no discussion. We live in the era where the patient should take their own decision. Our role is not to decide what to do. Our role is to consult them, to share with them all what we know about advantages and disadvantages of all the procedures, and let them choose one. It is a little bit complicated sometimes for patients to go through this decision making, but it's just like when you go to the bank and you want to invest your money. The banker will tell you, what do you want to do? You want to go low risk, high risk? You want to gain more, gain less? It's your decision. It's your life. So when I talk to a patient, I try to tell them all what I know, and then I try to ask them what they want, unless they ask me to take the decision. Mm-hmm. The second point, which is also very important, is that I am convinced we should move from a approach which is photographic. I mean, you take a picture of the patient, you take a decision now, which will last forever. This is a typical surgical. We look at long-term outcomes. We don't care. I don't care about what happens in 20 years. First of all, I need to get to 20 years durability. Durability is an important point, but it's not the number one point here. I think, first of all, we need to enter into era of lifetime management. And lifetime management means that any decision you take today will have a consequence not only in 10 years from now, but maybe 1 year from now. So there are many conditions you need to take in consideration. Obviously, if you go younger, there are a lot of questions. Will the coronary disease evolve? Will this patient therefore need a PCI, for instance? Will this valve last long enough? Will this, bicuspid valve a problem? There are a lot of issues, obviously. But again, don't think only about the long-term outcomes. I tell you this because I was debating maybe 2 weeks ago with one of my colleagues who is a little bit more, let's say, conventional guy who likes to operate 85 years old people with a surgical approach. He told me, you see, look at the PARTNER 3 trial. the two curves are joining again. Well, yes, and maybe there will be a crossover. And I agree with you that maybe in 5 years' time, maybe we will see that probably there's a little bit of advantage of dying less in 5 years' time. But in the meanwhile, you die more at 1 year time. So, you also need to understand that the risk profile of a procedure has to be seen over time. So the concept of lifetime management and the concept of taking the risk that the patient wants to take. Somebody wants to live longer, somebody wants to live now. So it's a difficult decision, and we need to be very, very well informed.
Thank you so much, Francesco. Very excellent point. Very well discussed. Dr. Mourjani, you were the source of all of this discussion here today. So tell me about your choices. So 65 years old, comes to your office tomorrow, actually Monday. Tomorrow is Sunday, so hope you have 1 day of rest. So Monday comes to your office and now has severe aortic stenosis and a low risk for surgery. Has the life of each one of us, a wife, a mortgage, a couple of kids. So what do you suggest him for his choice in terms of aortic valve?
So I share some of the comments of what's been said already. I think that the most important, thank you for the day off tomorrow first, just I forgot to mention that. I think the most important thing is that the patient is given the right evidence. I mean, we've all talked about the concept of a heart team, the interaction about the patient maybe choosing a less invasive option, but knowing that what the risks of those are. But I think the issue is that not all patients are given that full understanding of what the different options are and what the implications of those options are. Your concept of about life and the whole life journey is as important is correct, but we need to inform them of that. So I'm sure you'll all have seen, in response to the AHA guidelines that were put out at the end of last year, the Latin American Cardiac and Endovascular Society put in their statement saying actually they didn't believe in the AHA guidelines. They categorically said all surgical trials are based on surgical risk, therefore we cannot have age criteria. They said that there is no long prospective randomized study beyond 5 years. So if a patient is expected to live beyond 5 years, we should not be advocating TAVI. Now, I'm not sure I would go as extreme as that, but there is some merit to the argument or the points that they are trying to make. So in answer to your question about the 65-year-old that turns up, in my best impression, if the information I would convey to them about long-term durability, about a valve, the need for another operation, as Jessica mentioned, the concept of mechanical valve is often forgotten about in these discussions. It's just said TAVI or surgery, meaning bioprosthesis, and one or the other, you may get structural valve deterioration and need further intervention. So I think the crucial part of the whole debate related to this is about informing the patient properly. And that is where our results come in. And as I said, I'm involved with our national society, and we've got similar data related to that. 31,000 patients over 5 years, similarly 1.2% mortality and stroke rate at similar rates. So it is important that patients are given this information of durability, of paravalvular leak, of PPM, all of which have impacts on long-term survival, both quantity of life, but also quality of life. So I think these discussions need to be put to the patients of pacemaker, patient prosthesis mismatch, paravalvular leak, and the implications it will have if they're left with these potential complications after whichever intervention they choose. So they must be given the discussion. In my practice, a majority of them will end up having surgery.
Thank you. Very well taken points. And we will get back again on mechanical valves. I want to talk a little bit about it later on. But right now I want to ask Mario Gaudino and involve him in his Saturday morning in New York City in this conversation. So we spoke about randomized controlled trial and guidelines. So this industry-driven randomized controlled trial, guidelines that set an age to a different level that most of the cardiac thoracic surgeon has felt in an uncomfortable way. Where are we stand as surgeons in the decision making of these guidelines? What do you think about these ACC guidelines and the Latin American Cardiothoracic Surgical Associations ones? What is your position taken about that?
Well, thank you, Gianluca. I think first of all, it's randomized trial by definition are focused on a highly selected cohort of patients where there is, in this case, real equipoise between the two techniques. This patient population does not represent current practice, and it is the issue with low external validity of RCT. It has always been an issue, and it will always be. And this is why paper like the one that we are discussing today are very important, because they also give us a perspective on what happened in the real world data. On the other hand, I am here a little bit taking an unconventional position for a surgeon. I have criticized industry-sponsored trial often, but it is also true that it is the only trial that we have available. And this is, honestly, it's all of us fault. I mean, industry has a lot of problem in the way they design their trial. Don't get me wrong. Generally, people who design industry-sponsored trial are among the best trialists in the field, but they are biased, like all of us. And so they tend to design a trial that will probably tend to the direction that they believe is the right direction. If a surgeon designs a trial, would probably design a trial that is likely biased in the opposite direction. This is just a nature, and this is why trial results are just need to be discussed and interpreted. But the reality is that there has been no surgical lead trial. They have all been industry-initiated trials. So this is the evidence that we have, and this is the evidence we need to base our guideline on. In general, I don't think, and with all the due respect to the South American society, I don't think that you can disagree with a guideline. I mean, the guideline is, if you want, you can disagree with all guidelines, but still those are the guidelines. The guidelines are general expert opinion based on evidence, and this is what the AHA-ACC guideline is. If you had the different expert, you may have the different opinion, but this is true for all the guidelines that we have in our world. As a surgeon, honestly, I think we haven't done a great job in providing solid information on surgical AVR. It is true that we have 20 years of data, 30 years follow-up on our patient, but honestly, they are not great data. They are clinical data, incomplete follow-up. Probably the best longitudinal data that we have on surgical AVR come from the TAVR trials with, systematic echo, central core lab. We didn't even know there was subclinical thrombosis before the TAVR trials came to show us that that was a problem. You think that was not a problem earlier, when we were doing only surgical AVR? Well, I do not think so. So I think that we need to take responsibility for the fact that we haven't been smart in the way we have studied surgical AVR. We haven't made a lot of progress. I think we are doing AVR the same way we were doing it 50 years ago. And we have tried small incision. There is no doubt that TAVR is a real progress. And Francesco has a great point regarding the quality of life. My practice is 95% coronary, so I am in another field. In coronary, if you look at the CABG versus PCI comparison, for the full first year, the quality of life of patients who have bypass surgery is lower than the quality of life of patients who have PCI. So if a patient has a 3-year life expectancy, it doesn't really make a lot of sense to use an intervention that take a full year to recovery, especially because of the benefit of surgery are seen in the long-term follow-up. A long-term follow-up that particular patient is probably not going to reach. So in the end, again, it's not my field. I'm a coronary surgeon, but I think we should be happy that we have the TAVR option, because there are patients that honestly we should not bring to the operating table, and having the possibility of treating the aortic valve stenosis with an intervention that is much less invasive, it's really, really a progress for medicine and for the patient. And yes, we should do what Francesco is doing, being able to master both the technique and provide both options to the patient. There is a saying in the United States, the key to long-term success is short-term survival. And so, I mean, this is something that for some patients is particularly relevant. And remember, and I will shut down after that, I will shut up after that, but I don't think we should use, like I have heard several times, the same paradigm that we use when we compare CABG versus PCI, when we compare TAVR and SAVR. When we compare CABG and the PCI, we have two very different interventions that led to very different anatomic results that have very different effect on the coronary circulation. When we compare TAVR and SAVR, well, the two interventions, even though very different in terms of trauma to the patient, they end up with a very similar, if not identical, anatomic result. So the comparison is in a totally different level. And having said that, I'm just a coronary surgeon. Thank you for the opportunity. I will be here listening.
Thank you, Mario. As always, despite you're a coronary surgeon, it's an excellent and well-taken point. And I totally agree. I think TAVR made all of us better surgeon. And again, as I said in the first instance, and even Jessica said before, we are all responsible for the outcome of our patients. We are implanting bigger valves. We are more careful of our outcomes. And it's true, TAVR trials made us aware of problems and details that we need to be aware of. And it's our responsibility we have not done in the 20 years before. So it's a shame on us that we have never anticoagulated or studied the thrombosis on a small annulus valve and try to implement guidelines to anticoagulate small size valves. It's on our end. We have been master of surgical AVR since the 60s. So it's our responsibility. We have not evolved. One question, Dr. Mourjani, what is your feeling or your perception in mini-invasive AVR? Where should stand up? Do you practice it? It's part of your practice. How many of the patients involved in your paper were part of the minimally were done in a minimal invasive way? Do you think, as a role, minimal invasive AVR?
Thank you for that question. Yes, I do think there's a role. We've evolved in our practice that in the study, a small percentage, so less than 5% of the patients underwent mini AVR. We use that in our hospital. I think it is an important part of evolving. I think, as you commented, I think a lot of surgical practice doesn't necessarily evolve to the rate that it should, and that's for a variety of reasons. But I think it is important that we offer patients the whole spectrum of opportunities that surgery has to offer. And so whether it's through a hemistenotomy, whether it's a right anterior thoracotomy, whether it's sutureless valves or rapid deployment valves, I think there are all different gamuts of what we should be offering patients moving forward. So, and especially when we're talking about the concept of how these decisions are being made, about giving patients the options, about shared decision making as the main tenet that underpins our interactions with patients. So I think it is very important. Our study did not have a large proportion of it, but that does not mean that I don't value the importance of it. And I think for patients to have the full options, it is important to have that within one's practice. So, and I think it will continue to become a larger part of surgical aortic valve replacement.
I just want to share a comment regarding this that Dr. Lamelas did at the Heart Valve Society. So he said that with the current randomized trial, we're comparing Apple and Origins, comparing TAVI and surgical AVR via sternotomy. So what we should do is to compare mini AVR, either especially the one with right anterior thoracotomy, to actually TAVI, to compare apples and apples. That's a comment that he did, and this goes in regards to the evolution of SAVR, and that we were maybe stagnant at some point, and that we need to evaluate. We need to progress towards a more minimally invasive approach as well.
Yeah, providing you implant a good valve.
Yeah.
Very often, when you go minimally invasive, you accept compromises. I think this is a very important point, and we learned very well what that means, particularly in this so-called industry-sponsored trials. You know, when I hear this definition, I always shiver because you know, industry obviously has a bias, but they have a quality that the non-industry trials are not having, including the trial we're talking about today. I mean, excellent trial, excellent registry, retrospective. You know, we only know the outcome in the patients. You decided to operate. We don't know what was what was the characteristic of the low risk trial. So there are a lot of limitations also in the publications that we have been producing. The reality is that in a it was an industry the partner 3 was sponsored by Edwards, but the surgeons were not paid to make a bad job. So at the end of the day, it was an industry sponsored trial that showed that probably surgery should do better. And I'm very, very skeptical about sutureless valves and other tricks. Sutureless valves, for instance, I never implant them. I let some of my people from my team to do it, and I always have to discuss a lot because, I think they bring the worst of the two scenarios, of the two worlds. They have a lot of, they bring other challenges. I think as a surgeon, probably we should be very careful to embrace new technologies without asking questions. I see sutureless valves being implanted in some centers as a first option for everybody. I see new valves with new tissue, which is supposed to be super durable, which is being given to younger patients without any evidence about that. And we know what we're talking about. So there are a lot of areas where surgeons are actually behaving bipolar. On one side, they say, wow, TAVR, stop it, because the industry is paying. But at the same time, we accept some industry-driven information, and we go outside of the pathway without even asking ourselves where these data are coming from. So I think, and again, I would be debated for that because I'm always considered to be very biased by industry. But I think do not forget that industry has been a key element in the evolution of cardiac surgery. Without Medtronic, there would be no pacemaker. Without Alberstar and Edwards, there would be no valves, and so on. So industry, and we need to be very, very strong in this debate between industry and non-industry driven studies. But at the same time, we need to have a voice. And I think, honestly, the American Association guidelines, the HA guidelines, are crazy. I don't know why they took this decision. I mean, this is totally crazy. I try to understand where they found the data to support this indication, to be honest, because those trials were not enrolling patients 65 and older. So again,
but some of that discussion comes with actually, which is some of the controversy that came with previous guidelines, is about who is on these guideline committees. I think you'll have seen there's a recent publication by Hinton and Benoit Shah in Clinical Medicine a couple of months ago, which showed actually for the European guideline committees, up to 80% of them have a conflict of interest. So they get direct payment from the company, they get their research funded by the company, they have intellectual property with the companies. And so actually, the most recent guidelines published by the British National Institute of Health and Clinical Excellence actually has gone against the standard guidelines for TAVI. Now, you could argue both ways, but they've actually said where surgery is an option, surgery should be performed. It said the cost effectiveness of TAVI does not merit its use. So they are looking at it from a different angle. They're looking at individual needs of patients, but also from a population base. And they're trying to look at the cost effectiveness per quality. And they've said, actually, if surgery can be performed in low, intermediate, and high risk patients, TAVI is not cost effective. Now, I understand the discussions we all agree about, there are merits for them, but it is understanding that actually some of the guideline committees, individuals do have a conflict of interest. In that same Hinton paper, they looked at 2 hematology guideline committees, one where conflicts of interest were not allowed on those within the committee and those that were, and they came up with completely different guidelines. So we need to also be aware of the people that are writing the guidelines, that it is, I think you said right at the start, we all have innate biases within us. We all have prejudices and ideas of what should and shouldn't be. And so it is actually sometimes very difficult to move away from those innate unconscious biases that you cannot change. And maybe the one way to change that is, as the National Institute of Health and Clinical Excellence did, they excluded anyone with any potential conflict of bias before the guideline committee was constructed, and therefore the guidelines were made.
Yeah, can I add something on that? I mean, this is not as simple, even though your point is very well taken, but it's not that simple. I see 2 main problems. First of all, probably among those who have most knowledge and content expertise have a relationship with the industry just because they are more active on the research side, and so they get in touch with industry. So if you just have a blanket rule that nobody with conflict of interest should be allowed in a guideline, you may risk cutting off the best of us, those who have more knowledge. And I don't have any conflict of interest, just to make clear. But so I'm not advocating for this reason. But I think this is something that you need to consider. I mean, if your focus is mainly clinical practice, you don't do a lot of clinical research, you are unlikely to have a conflict of interest. If you have devoted all your career to clinical research, you probably at some point have worked with industry. I would prefer the second guy to be on the guideline, not the first guy. So that's one point. But also, I don't think that the conflict of interest are necessarily only financial in nature. I think the strongest conflict of interest may be actually non-financial, may be related to what you do every day and what probably drive not only your salary, but also your scientific reputation, your visibility. So I get your point, but the solution, I think it's much more complex than just looking at relation with industry.
And don't forget that those who have less, that many of those who are not declaring conflicts, they have a lot of conflicts which are hidden, particularly in the medical guidelines. You know, in many committees. There's a lot of problems with that. And I think I can't agree more with Mario. There is a lot of discussion to eliminate everyone with a conflict of interest from the guidelines. On the other hand, if you do like that, you will have probably less competent people around the table. The other point about the NICE, I totally agree with you that health technology assessment is a great way to value a procedure. And I totally agree with you that we should have a social look at, let's say, these procedures and sustainability. And the problem is it sustainable? And there are many ways to be sustainable. I tell you one example. I just came back from Switzerland and went to Italy, and specifically to Milano. Let me tell you the story. I'm very much informed about access of therapy within Europe. Europe has a diverse situation where if you live in Germany or Switzerland, everyone gets very highly technological treatments, new treatments, a lot of TAVIs, a lot of mitral clip, whatever. If you live in Eastern Europe or in Albania, Greece, you will probably not get much less of that because there is no money. Italy is in the middle. Then I went to Milano and I found out that most of the procedures are not reimbursed by the government, the regional government. And the answer to that is that, to reduce the risk of non-appropriate use of these devices, they lowered the reimbursement. So, for instance, for a valve in the mitral position, you get a reimbursement of 5,000 euros against a cost of the device, which is between 15 and 20,000. So, in principle, if we go down into economics, there is another risk that we also lose the center point, which is at the end of the good for the patients. And again, the quality, the cost of quality, or let's say the health technology assessment highly depends on the cost of the devices. As you move forward, the cost of the device will be reduced. Today, a coronary stent is sold for peanuts. It was 6,000 only 5 years time, or maybe 10 years time. 10 years ago in Europe, you would pay 3,000-4,000 for a stent. Today is less than 100. So everything moves, and the economical background and the financial background of decisions is also another misleading factor.
Thank you so much. Thank you for everyone. I think it's an excellent question. I want to ask Irbats, who is here with us from the I6 program of Yale. Give us some perspective. You're a young surgeon. You are training yourself right now. What's a young surgeon perspective of all of this discussion? Where do you see yourself? AVR, surgical AVR, TAVR. Where do you think you want to train?
Thank you very much, everyone. My comment is actually in the form of a question. It's what should be the approach for young trainees like myself and others who are presently training in different cardiac surgery programs around the world. And as I was just about to say this, there is a comment here that says it's hard for surgeons in developing countries to have training and availability for TAVR. That is one of the considerations here. And also, we spoke about SAVR being stagnant over the last 50 years, not having improved much. Where do you see improvement in SAVR? How can it be improved? How can we incorporate it in our training? Should all trainees aim to dedicate a proportion of their training to TAVR? Or should it be a super specialty? These are some questions that I have seen frequently, and they come to my mind naturally as a trainee. And if you can also comment on how SAVR, as researchers and future scientists, what can we do to improve SAVR? If we can comment on this, please.
Thank you for your question. If I can comment, we wrote a paper with, it was led with Tom Nguyen, who were young surgeons and mentored by more experienced surgeon. So what came out from this paper is it's now very important that every surgeons to continue to leverage their knowledge and experience treating valvular disease and obtain the necessary skill set to achieve and participate in structural heart disease. The greatest obstacle that I could see right now for the young surgeons that are already in practice or for current surgeons is to access to a formalized structural training. And I think that for the young surgeons who wants to do TAVR, I think that the option is to go in a formalized 1-year fellowship to obtain that, just to have the recognition from the cardiologist. Because the cardiologist, other than that, another obstacle is that they don't see an incentive to have a surgeon doing the procedure. They want you to be involved in the decision process and everything, but when it's time for the procedure, you're going to be either the surgical backup or you're going to be the second assist, or you're going to be the assistant. So it's really important that young trainees be involved in those training. We start in Montreal to do a 3-month rotation as an introductory to structural heart disease for our resident. At some point, if some are interested, they would have to do a formalized training. Other than that, for surgeons that are currently in practice, will it be proctorship in different hospitals to go with a surgeon that are already doing this and to have a certification to do TAVR? But I think it's really important to be involved and to stay relevant in that field.
If I can give you an advice, forget about what you do. It's not important. Now, how you do it, today we talk about TAVR. Maybe in 10 years' time, when you will be busy, there will be wireless implantation. I don't know, whatever. So the problem is, in my opinion, the main reason why surgery became cornerized or became a little bit less influent in the current cardiovascular scenario is because, unfortunately, many surgeons became a little bit lazy and forgot that before being a surgeon, you need to be also a cardiologist. You need to understand the disease. You need to know everything around that disease. So when you ask me, what is the future? What should I do to be successful? I don't know. That's your life. My life is already behind. Your life is in front of you, and you need to be ready to adapt to the changes that will happen again. There will be another change soon. We don't know where. And the only way to resist to the change, or let's say to survive the change, is to change your mindset from skills to competence. In my team, I don't need people with skills. I don't need that. I mean, everyone who has a skill can be replaced. I can teach the skill to somebody else. To build your competence, it's a lifetime. And so competence, in my opinion, will keep you busy for the rest of your life. What that means, I give you my example, for instance. I made a career, I think a pretty good career, because I made a decision. One day I said, okay, stop. I want to learn TAVR, yes. I want to learn MITEC, yes. But I will stop trying to go to progress my surgical skills outside of valvular disease. That was a decision, difficult decision, because I was, as every surgeon, trying every day to do something new. A little bit of Occam, a little bit of coronaries, arch surgery, this, that, blah, 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 robotic. Stop it. So I focus on one topic, and the focus means you need to be inside of the pathway, inside of patient pathways, and play a major role, not only because you can use a knife or a catheter, but because you understand that each step of the decision making, you understand the process, and you have an insightful, let's say, role in this pathway.
Thank you. These were fantastic, Francesco. I put your change your mindset from skills to competence as a baseline of our, because it was a very good. Narain, please, a very brief comment, and then we will ask a final comment from Thomas. Narain, what is your suggestion for young surgeons?
I think it follows on from the last comment. Is about being inspired and see the journey forward. It's easy to talk about some of the processes that have happened already, but medicine, surgery, treatment of cardiological disease will evolve rapidly, and you need to be a big player in that. Learning wire skills, I'm sure, is useful as a basis of a start, but I think it's thinking broader and bigger than that. You want to be able to drive the change on how you feel, how patients can best be treated. And I think, I think be inspired would be my suggestion to you. And open up the different horizons, and the world is your oyster. So good luck on it.
Thank you, Narain. It was a great discussion and great paper and great comments. Thomas Salerno, Professor Salerno, a word of wisdom from the editor-in-chief of Journal of Cardiac Surgery. And you have seen a lot. Tell us, what is your perspective about TAVR, SAVR, present and future perspective?
First of all, thank you all for this fantastic discussion. I think you gave a very real world view of where we are in this field. For those of us who lived through this, and you perhaps could read the article I wrote in the 80s in CTS.net called In My Opinion, in which I was pleading with cardiac surgeons to get out of the operating room and get involved into percutaneous and other procedures. At that time was primarily endovascular stenting, was actually being done by neurosurgeons and radiology, not by cardiac surgeons. So I always ask the question, and something that a young generation looking to the future should ask is, who should have been at the end of that catheter? And I don't have to give you the answer, but we did not have the vision of where this field was going to go. I watched Grunzig give his lecture in Vancouver, and the cardiac surgeons did not believe this is going to be successful to put a balloon through a coronary artery. And to their surprise, there was a lot of stenosis. However, came the stent. And basically, you look at the evolution of PCI over treatment of coronary artery disease. And the other thing is, I think I'll remember when Cribier put his percutaneous valve, I never thought it would work. If surgeons see this valve calcified and compared to a radiologist who just see a picture, or a cardiologist who just see a pictures, and it basically changed our field. And all you have to do is the number of TAVRs and the number of SAVRs in any center. And the fact is, primarily in the United States, that we do not see patients. The decision, we are totally involved, which is making the decision for, and then the procedure is majority done by cardiologists. So they see the patients, and also even for cardiac surgeons, it's eye-opening to see a patient post TAVR in the morning. They're ready to go home. By the way, I just want to clarify what minimally invasive is. Invasiveness, according to Calafiore and me in a meeting in Rio in the 90s, is the use of the heart-lung machine. This is not minimally invasive. This is cosmetic aortic valve. Invasiveness, you still put the patient on pump, you clamp the aorta, cardioplegia. Obviously, there are benefits. I'm not saying there are, but the patients get an idea that this is really minimal. It is not minimally invasive. This is actually maximally invasive through a small incision. For those watching this program, reflect on this. Some majority of cardiac surgeons are flying propeller planes. We're now flying supersonic jets. We're going to Mars, to the moon, and we're still doing surgery the way that we did in the 80s. When you look to the future, we're in the first, second, third generation of percutaneous devices. This is not going to quit. The investment, I was looking the other day at the investment by industry in research for cardiology and cardiac surgeons. They're all in cardiology. Industry investment is in cardiologists. We need to get involved into this field. Somebody thinks that the train has left the station. well, maybe we can still catch the last wagon. I wish I was born today. So I want to give those in training a view of the future, that this is the opportunity for getting involved in this fantastic field, because we can all be participants.
The dog is agreeing.
Yeah, just for everybody to know, the dog, Tom Salerno dog, is officially part of the Journal of Cardiac Surgery, so he can bark all the time.
The dog was the right hand. Thomas.
I had to mute because they're all barking, but I really enjoy very much participating in this meeting. I really want to thank you all for the outstanding discussion. I really appreciate this.
Thank you, Dr. Salerno. Thank you, Dr. Gaudino, Dr. Morjali, Dr. Forcillo, Dr. Maizano, and Gianluca. Thank you, everyone in the audience as well. We are a bit over time, but just before ending this, I would like to remind everyone that there is a special issue on aortic surgery now on Journal of Cardiac Surgery. Please check it out, and it's got a lot of content that should benefit everyone in aortic surgery, as well as all cardiac surgeons. With that, I will thank everyone again, and we will be back next month with another issue of the Live Talk. Thank you again, everyone.
Thank you, everyone.
Thank you for the opportunity to talk about our paper, and thank you very much.
Thank you so much.
Thank you all.